Good morning and good afternoon. Welcome to today's webinar, Prior Authorization, KPIs, and Frameworks for Performance Evaluation. My name's Phil Dolan. I'm Chief Growth Officer at Valer. We're a provider of automation technology that speeds and simplifies prior authorization management by automating submissions, status checking, and verification. Before we get underway today, I'd like to share a few housekeeping notes. First, today's presentation portion is planned to run about 45 minutes with an additional 10 to 15 minutes at the end for questions. Our webinar is designed to help educate you on an approach to improving prior authorization management, leveraging key performance indicators. There's no product demo today, but there will be an opportunity at the end in the survey if you have a request for follow-up from either Valer or the Wilshire Group. Even if you're not looking for help with prior authorization management, we'd love to get your feedback on today's webinar. Survey respondents to a simple 5-question survey at the end will be entered to win a $100 Amazon gift card. So remember that you've got to be in it to win it. We invite your questions throughout today's webinar, and we'll address as many as we can at the end. You'll find a Q&A button at the bottom of your screen, and I'll read your questions to the panelists at the end. You may also use the chat button if you want to share any thoughts with other attendees or our panelists. Finally, we'll be recording today's webinar, and we'll make both the recording and slides available, and we'll send both to you next week. I'd now like to introduce you to today's speakers. First is Dr. Steve Kim, who's co-founder and CEO of Valer, again, a provider of solutions that automate prior authorization management. With more than 20 years of medical experience and a passion for studying value-based care outcomes, Steve's expertise has been vital in navigating the evolving complexities of the healthcare industry and identifying the administrative roadblocks and bottlenecks delaying access to care. Before his transition into entrepreneurship, Steve was an assistant professor of urology at the University of Southern California's Keck School of Medicine. While at Keck, Steve also served as director of clinical research informatics for Children's Hospital Los Angeles, in addition to practicing pediatric urology. He earned his undergraduate degree at Yale University and was awarded his medical degree from Cornell University's Medical College. Tim Holland is a director with the Wilshire Group and an accomplished revenue cycle and patient access operational leader with 20 years of experience in the field. He has worked in multiple large health systems across the country in various operational and consulting roles. Tim has a great passion for improving both a patient's customer and financial experience with their chosen health system and truly finds joy in identifying and optimizing operational processes within referral management, patient scheduling, patient estimates, time of service collection practices, denial management, and operational leadership. Tim excels in improving patient experiences and optimizing operational processes in healthcare systems nationwide. Beyond his work at the Wilshire Group and at health systems, Tim has served on the board of directors for the National Association of Healthcare Access Management. With that, Steve, I'll ask you to take it from here.
Wonderful. Thank you, Phil. Thank you for all of you who have joined us today for this webinar. And an extra special thank you to Tim for joining us to talk and share a lot of his perspectives and expertise. I've had the pleasure of getting to know Tim over the past year, and we've had a lot of really great discussions about prior authorizations and how to start thinking about helping organizations think through these problems. We hope this will be a useful webinar that will stimulate some discussion, some thought amongst you and your teams. The agenda for today, one, why is it important to kind of get prior authorizations right? Key prior authorization challenges, just to kind of lay out some of the workflow considerations that are involved. The next is really which prior authorization KPIs might be of interest to measure, and more importantly, why. And I think Tim will lend his expertise and perspectives around that. And then really some thought into how to measure and obviously to meet key performance indicators that as it pertains to prior authorizations. Can you go to the next slide, Phil? I'll kind of turn over to Tim to kind of talk a little bit about some of the risks.
Yeah, thank you very much, Steve, and thank you for having me on the webinar today. I've been very excited about this. Authorization is a very timely, costly process that most healthcare organizations have to go through on a daily basis, unfortunately. And it's very important that what you're having to do and how you're having to do it, you do it right. Some of the risks around what can happen if you don't get it right. Things like delayed patient care. We can have patients be pushed out a little further than they may need to be if they're waiting for a particular scan to happen before care can continue, say with cancer patients, things of that nature. That can also have a negative outcome in terms of clinical outcome risks. Patient leakage, if you don't have an effective process around authorization and do it relatively timely, patients can look elsewhere for getting their procedure done, which is a revenue loss, a patient satisfaction issue. There's a lot of things kind of covering that. Also hurts, having to reschedule patients to a later date. Also a patient satisfaction issue. Also creates holes in your schedule. So from a resource underutilization perspective, it creates a area where you're not going to be able to maximize the production of that particular MRI machine or a particular OR, which you may have to do. And then having to just go through the whole rigmarole of claim denials and lost revenue and having to fight the denial and appeal the denial, and also have a lot of items where you're spending time, labor, and money just to fight and get what you're rightfully owed.
Yeah, absolutely. And as a pediatric surgeon, these were all the frustrations that I saw in my own practice that actually caused me to get very upset one day over a decade ago to start really drilling in on, how do we start improving prior authorization workflows? Because I was just really tired of it impacting my patients and, of course, my practice, right? So all those things are pretty critical. I'm just going to talk, we've been doing this for about 10 years at Valer in terms of speaking with a lot of organizations and talking to a lot of some of the key challenge points when it comes to prior authorizations. And I'll just highlight some of the things that we've certainly heard over the years and also focus on addressing at Valer. First and foremost, for any of you that have teams that are or done prior authorizations, they're incredibly manual and they're incredibly costly to kind of manage. This is really the payer websites, the faxes, the phone calls. There's some data from surveys from the CAQH index report. CAQH is a industry collaborative looking at administrative costs in healthcare, and their last index report stated the average time spent per auth is about 22 minutes at an average cost of roughly around $11. So it's a pretty costly exercise when it comes to prior authorization management. Certainly as a provider, as Tim alluded to, there's a lot of other clinical impacts and operational impacts that also get in the way because of this manual process. The other part that we always hear about is just the frustration with all the manual data entry that has to happen between EHR platforms, practice management systems, and just all the multitude and fragmented payer workflows and requirements that we'll all have to deal with for prior authorization. So what we see frequently is a lot of manual typing of information back and forth between an EHR platform and all the different payer websites or filling out fax forms. And so it's another component that we focus on. I think most of what we'll focus on today's webinar is really the next two: lack of staff visibility and payer performance. Certainly when I was a physician in practice, I would always turn to my manager and say, hey, what's going on with these prior authorizations? Why can't I get my patient in the operating room? Why can't they get the nuclear medicine instead of the MRI? And so there are a couple of components that we started to see because it was so manual around the lack of understanding kind of staff productivity and throughput. But more importantly, also the craziness that we all know is the payer response and performance. And so how do we start putting some more information in front of people to start looking to find ways to optimize that? And so we'll hopefully cover some of those aspects of it. And obviously, identifying those areas where people are running into issues, whether it's an unnecessary avoidable denial, both in terms of not allowing the service to happen, but also as Tim alluded to, we know that prior authorizations is frequently one of the top reasons for denials and write-offs after the fact when it comes to the revenue cycle. So we hope to at least provide some frameworks to look at metrics to measure, but then to also hopefully help you and your organizations optimize some of these challenges. Next slide, please. I'm a pretty visual person, so hopefully this is what we wanted to do here, is to put this in context. So as a physician, obviously I see a patient, I drop the order, the appointment is made, and what does it take to kind of get the patient to get the service, in this case, whether it's an MRI, into the OR for surgery, you name it. And so there are a lot of things that are intervening when it comes to the prior authorization process. Obviously, as we talked about, a very manual process frequently of submission or initiation to all the different various payer websites, to the various payer fax forms if those are still being required, and just the endless hold on phone calls that I'm sure all of you are familiar with. And so part of that is the process that is very manual that we had kind of described earlier. But on top of the submission process, obviously there's kind of closing the loop in terms of verifying status to make sure that you have a secured authorization ahead of an actual service that's happening. Next slide. So we're just going to kind of put in a little bit of laying out some of the framework for thinking about some metrics that may be interesting or important to measure. Obviously, at the start of this entire process flow is just understanding kind of how do you start thinking about what is the staffing requirement, what is the capacity needs to get through all the authorizations. The next part is really how do you start getting a better sense of what the payers are doing, right? So what are payer decisions looking like? How long is it taking for turnarounds to occur? What type of results are you getting? Denials, approvals, redirects, peer-to-peers that are intervening? And then also, to Tim's point earlier, these things all factor from an operational standpoint into scheduling, operational efficiency, running into issues with referral leakage or patient leakage because they're just tired of waiting for the process and may go to another institution. Patient dissatisfaction with rescheduling and cancellations. I've been there, and so that's partly why having those metrics are important. And other kind of overall process metrics to help you kind of instrument and see how things are going. Auth days out is something we'll touch on. Auth resolution rates, and obviously auth denials and write-offs as a function. So hopefully this provides at least a visual map. The next slide is really much of kind of putting this into a framework of, and what Tim and I will cover here and try to walk through in terms of KPI frameworks is capacity planning. Once again, what is the volume of work that needs to be done and the staffing that may be required? What is your staff producing? How much are they getting through? What is the throughput? Payer performance. So this is a big factor for a lot of us in terms of what is in the way in terms of smoothing out the operational scheduling process for a lot of our services. And then just really kind of highlighting some general overall process measures that looking at the health of the entire process itself. There are a couple of quotes at the bottom there. Oops, sorry. That I certainly have learned to appreciate in my time as an outcomes researcher, as a physician, and through this process is Peter Drucker's famous "You can't manage what you don't measure," and so much of this is manual and in the dark and difficult to understand. So we want to provide some information there. And another one by John Doerr is a famous kind of investor who said, "Measure what matters." And so we're not promoting having way too many metrics and measures and having just really focus on things that are going to help you guide how to optimize and improve your processes. So we'll go to the next slide. And with that, I'm going to turn this over to the expert here, Tim, in terms of looking at staffing and capacity, looking at capacity.
Yeah, thank you. So just to kind of start, this is looking at things from more of a central structure or more of a standard and organized structure. I know some organizations out there like to handle authorizations on a clinic by clinic or service by service basis. So just kind of keep that in mind. But definitely things you want to consider if you are looking to standardize and centralize, or if you're currently doing it, but you're having some FTE, problems, too much volume per FTE, et cetera. Make sure that you're looking at what your overall estimated number of prior auths are in terms of what you're expecting to come in. If you have EMR auth historical data available to you, depending on the auth, or depending on the EMR, that's even more valuable because you can kind of start projecting things going into the future based off of actual data that you have. Also look at, how many FTEs are currently doing authorizations, and then what is the average amount of work or productivity that you have per FTE. Is it too high? Is it too low? Could we be doing more? Could we be using tools such as Valer to help, speed up and standardize the way we're doing a lot of these authorizations? And then also look, how long does it take per authorization for you to do that? That CAQH average is a great average, but that's typically like a national standard. That's going to differ a little bit region by region, and even state by state in some cases. Medicaid, I'm sure everybody on the call is very familiar with. That varies by state, across the board. And sometimes that can be a very easy process for certain states. Sometimes it takes days to get an authorization taken care of. You're also going to want to make sure you consider your payer mix. So if you have a high managed care volume coming into your organization, those are typically going to be more efficient, a little more standardized than say some of your Medicaid. Not always the case. There are some managed care players that don't like to play nice or play in the same sandbox. And then also, look at your service types. So if you're looking to centralize around a particular service type or a variation of service types, make sure that you're taking that into account when you're trying to organize and structure the team. So all of that kind of factors into what the overall equation needs to be. So you're looking at your auth required times the average number of minutes needed per authorization. That's going to give you kind of your total minutes needed per auth. And then how many available minutes are in your FTE's day, and how long is your operational day on top of that. So if you're working on a 10-hour day and you're kind of staggering your FTEs to come in, you need to factor that in as well. But that's going to give you kind of a good target to hit in terms of number of overall FTE staffing requirements that you have.
Yeah, absolutely. And that's actually an area, Tim, that where we have conversations where a lot of organizations sometimes at first have some difficulty in figuring out how to understand what their total auth burden is. So I think that's a very good example of some ways to think through it. Just to understand what is the burden, what is the bulk of work that you all need to get through, right? So just to understand how to break it down. So incredibly helpful.
And just to kind of add to that, in my experience, in most cases, centralization is a very good way to start moving towards if you're not a centralized shop today. There's a very strong business case for it. Typically, there's labor savings that can go in with that, and a few other items that can just help push your off days out even further into the future than you may currently be. And it can become more consistent across service types and across service lines than it may be today as well.
Yeah, absolutely. We have a lot of conversations with organizations that have started centralized pre-access teams to handle authorizations, but many may be in a mixed situation where it's still being done at the ambulatory clinic level. And so for sure, really understanding what is the total requirement of authorizations. I'm going to move into a little bit of the staff kind of performance and productivity. So you've kind of understood what your total amount of work that has to get done, and then you start kind of drilling into a little bit about what your team is able to do. Obviously when this is a manual process, it's very difficult at times to really track what is actually, the staff getting through in terms of authorizations, because it happens frequently outside of your EMR or EHR. And so this is just some of the information and data that is available from some of what we do at Valer in terms of helping to automate and facilitate authorization submissions as well as verifications, and being able to start seeing actual granular data. This chart here is over, counts from a group, a team, a clinic team of how many authorizations individual users are being able to submit from week over week, just to be able to track the ebbs and flows. And so it has been incredibly useful for organizations that we work with to really be able to see the productivity as it happens kind of in real time, understand where the bottlenecks are, where they may need to load balance staff, where they have some people out and they need to catch up. So it's been one of those areas where you put the number of authorizations you need to kind of get through, and then you're starting to understand what is the productive capacity, if you will, of your staff. And so just more information that is very helpful from an operational standpoint when we talk to a lot of our clients and partners. Next slide. It's another example. This maybe gets to Tim's consideration of like taking into account the type of service that you are looking for authorizations, but really being able to start benchmarking kind of what your staff has the ability to kind of, process when it comes to authorizations. This chart here is a couple of different individual users taking a snapshots from an organization month over month, kind of what their productivity levels are in terms of the total count of authorizations being performed. You'll notice, and this is something that we routinely see with almost every one of our clients, is there's obviously a variation spread. And so you really want to understand, kind of drill in to make sure that you're really taking into consideration what their workflows are. So the low counts may actually end up being really difficult, complex infusions. High counts may be something a little bit more straightforward, like diagnostic imaging. Tim alluded to the Medicaid population. Certainly, I'm very familiar, having worked in California, with every E&M sometimes having to require authorizations. And so really to take that into consideration. But the real beauty here is to really start understanding what are your teams actually being able to produce when it comes to prior authorization productivity, and to be able to see that and visualize that. And it also provides some information that to help optimize how your teams are running. This is another example of just what we frequently see. This is a chart of just over time, historically on the x-axis, and authorizations being submitted, but understanding different users and team members and kind of how their behavior and ramp up period happens with authorizations. You can kind of track and trend and understand what is the ramp up time for folks, and kind of what does the education process look like. I think one thing that we find is that there can be a lot of variation when it comes to individual staff members. And then obviously there's a lot of learnings that we have seen organizations take on as they start taking best practices. And sometimes it's a matter of education. There could be a huge uptake in terms of that dark blue line of someone who, with some education and orientation to kind of processes, where it allows people to have really significant jumps in productivity. And so really looking at this as a tool to kind of understand what is your overall staff capacity and how do you start optimizing. I am a fundamental believer in training, and education goes a long way when it comes to your financial counselors and your patient access reps, in terms of standardizing what you can standardize when it comes to prior authorization. So just another bit of useful information in terms of looking over time.
It's also worth mentioning that your education, just in your general staff, in terms of like their knowledge of all processes and all requirements and what's required from, like, say, a UM perspective or something like that, is what you have kind of going into a go live with Valer's product. That's going to have a direct correlation with how quickly you're able to kind of jump into the product and how much your productivity is going to launch. And I'm sure that data would reflect that a little bit if you dug in a little bit.
Yeah, absolutely. And we're constantly looking at kind of what is the onboarding process and ramp up time and education process involved, for sure. In addition to kind of just at the kind of higher level of what is the throughput, one of the nice things that we've been able to do with our platform, because we are automating and doing submissions for folks when it comes to payer websites, is really being able to really drill into some granular information. This is a sample of different payer websites. And so how long is it taking to go ahead and submit for an authorization across various different websites when it comes to minutes? And so this is with automation. There are some that require human kind of answering of clinical questions that are factored in. But we also, just like the slide before, seeing kind of an understanding of, on average, how much would it take with the automation versus with manual processes, can kind of help factor that into your operational efficiencies. And also, this is another area where we do see, pretty wide variation from time to time between different users, where there could be training and education to help navigate some of that as well, to drive some more efficiency. So really having detailed visibility into what your people are able to get through, how long are they actually having to spend kind of doing the manual work, and how much automation can be driven into it, is something that goes into, I think, the little bit of the calculations and the math that Tim was providing earlier. All right. Going to kind of jump in here a little bit on now moving from the staff performance part to the payer performance part. Obviously, this is an area that has been a huge point of frustration for many of us, in terms of just dealing with some of the requirements, some of the lack of certainty or clarity as to kind of what to expect with many of the organizations. I do want to call out that the Centers for Medicare and Medicaid Services, or CMS, earlier this year in January, did pass what they call their prior authorization final rule. And just going to highlight some of the timing factor. So as part of that rule, payers will be required to respond to urgent requests for prior authorizations within 72 hours, non-urgent requests to be responded within 7 calendar days. And we know that there are plenty of states that have their own individual state-based requirements that are also coming out. So there is a lot of frustration and therefore a lot of regulation that is on the way that you should all be aware of when it comes to prior authorization response times from insurance companies.
Yeah, one thing I'll add here is that if you weren't aware of this final rule, this is something that the next time you have conversations with, say, your managed care team or even with the payer directly, this is a way you can hold their feet to the fire and really say that we have to, you as the payer has to meet these requirements. We're going to be tracking this on our end, and let's work together to make sure this is done on both sides of the aisle.
Absolutely. So one of the questions I always asked of my manager was, how long is it taking for Plan X, Payer Y, and Payer Z to return an authorization approval? And through our platform, being able to kind of manage the submissions and the response retrieval process, here's some information that may be interesting. We certainly find that most organizations we talk to, when we show them some of the data, it is very eye-opening at times. This is a large ophthalmology practice, and kind of what you're seeing here is on a monthly average basis. All those bars that you see that are reflected are individually unique health plans or payers. And on the y-axis is how many days they are turning around responses, whether it's approved, denied, et cetera, as a kind of a final status. And you can see that much like lots of things, it's quite variable. You have some that are clearly outliers. And I've taken the liberty of drawing in what can be, what will be the kind of the regulatory requirement for those health plans covered by CMS in terms of the 7 days for the routine turnaround time for responses and 72 hours for urgent. So really understanding how do you start plotting how long is it taking to get a response on average from a payer. This can be broken down into specific individual service types or service lines, whether it's imaging versus surgery, et cetera. So I think this is pretty useful and powerful information. And Tim, I don't know if you want to talk about how this might be utilized from an operational standpoint.
Yeah, the first thing that comes to mind is what kind of impact this can have on your scheduling process, especially if you're an organization that schedules before you authorize, and factoring this in any type of decision tree logic or things that may push a patient to an appropriate time frame based on the turnaround time and the auth needs that you have with a particular payer. So utilizing this data in very unique ways, again, from more of a schedule first perspective than a auth first perspective, but just making sure that you're giving your authorization team enough time to complete the auth, and that would in turn reduce the likelihood of a reschedule or a things of that nature that can just create holes in your schedule that you don't want.
Yeah, absolutely. And certainly in our conversations, it seems almost 50-50 split out there between auth before scheduling versus schedule before auth. And so we have had a client utilize some of this data to start flipping to schedule before auth, having a little bit more consistency and understanding what the payer turnaround times are.
If you are an auth before schedule shop, this is something that you could also use to, better prepare your teams or your FTE model for this authorization process, and make sure that you're accounting for, you may have just 100 authorizations come through a day, but if half of those authorizations require more clinical information or have a long turnaround time like this that requires you to go back and check and check and check and check, that's time that you're taking away from the next authorization that you should be working on. So that needs to factor into kind of your FTE logic as well.
Yeah, no, absolutely. Wonderful. Next slide. So in addition to kind of payer turnaround times, frequently it's we all kind of have a rough sense at times, but to just get real data about what payers are actually approving what they're denying, and having kind of real clear information about it can be incredibly powerful and useful. What you're seeing here with all those individual bars are individual health plans and payers. And the light blue is the approval rates, the purples are denial rates. And so you can see kind of both what the percentage or fraction of the requests that are being denied are for a particular payer, and also some of the volumes that are being pushed through, to give you a sense across your payer mix. Another
Yep.
part of what we have done for clients is actually provide detailed information by specific health plan as to kind of on a monthly basis, what are their decisions between approves and denied, and getting even more granular into giving you account of what specific CPT codes are getting hung up and causing denials to happen over and over again. And so certainly, Tim, I think you can probably talk to how this might be helpful or useful for organizations.
Oh, this is one of my favorite slides in the deck. So just looking at, not only denial rates at this level, but going that level deeper, even further than just looking at the CPT codes that are getting denied versus not. What's the reason for the denial? And then once you kind of have enough historical data to say, I'm getting denied for this CPT 30% of the time, and all the time is because of lack of clinical information for a particular payer, you're now able to start preparing and accounting for that earlier in your authorization process to then prevent the denials from ever happening in the first place. So just having availability to not only this data as it's shown here, but the granular information underneath is going to be extremely valuable in terms of how you manage your team.
Yeah, absolutely. We've actually had one of our clients take the data where they were hitting 99% plus approval rates, and they actually use that as a tool to go negotiate to remove authorization requirements for a particular service that they can mutually agree to. And obviously, with considerations around gold carding efforts that are happening from state to state, this is another factor to go into that to help push for more and more gold carding that's out there.
Absolutely.
Next slide. So another thing that comes up quite frequently is just the question of no auth required, which plans for which services where there might not be an authorization that's actually required, yet teams are still having to go through the work at times, which is frustrating just to find that out. It's not always clear from payers. There are some payers that are very clear and specific, but many that aren't, where you've got to go to the websites or kind of deconstruct contracts and rules to try to figure that part out. There is something also in terms of help on the way from the CMS final rule that we alluded to earlier, that payers will be required to provide more transparency around what services require an authorization, something called a coverage requirement determination, or CRD, and to make that more machine available via what's called APIs, or application programming interfaces. So we do hope that the question we get asked all the time of like, is an auth required or not, can become less of a question for many of us. What you're seeing here on the chart here in the hot pink, those are things where for organizations we work with, where we work to configure understanding of the rules where no authorizations may be required, just to see that that would be no auth required workflows that we can build some automated workflows in so people aren't manually touching. The gold is approval, the dark purple is denied, just to give you a sense across individual health plans, which each of these bars represent, of some of those workflows. And as you can probably imagine, the really tall pink one is a Medicare plan, where authorizations are really not required for much, if anything. And so just another example of helping to provide some visibility.
No, this is also justification for, both internally and with the payer, to better prepare your teams again. If you work off of authorization work lists, so you're going from auth to auth to auth, this is a great way to analyze the data and remove a lot of the noise and the invalid work out of your work list and focus on what remains. So again, just great job in terms of just compiling the data, looking at it in a very organized fashion, and being able to go to that deeper level to be able to kind of utilize that in an organizational capacity.
Next slide. All right, the last, I think, area, just looking at overall process health measures that might be useful that we know a lot of organizations are measuring. We'll go to the next slide. Authorization days out. This is a report or a case study from one of our clients, Oregon Health and Science University, that they've been very gracious to share and present on. Authorization days out, which is the calculation of from a scheduled date of service, how many days prior to that is authorization being secured. is a number, and we worked with them prior to working with us. They were about 3 to 5 days, and certainly they were very happy to kind of extend this out to their target of closer to 14 days is where they wanted to be, and they were now at 13 plus days out, and so that helps reduce cancellations and reschedules. And some of the other aspects that they measured that help them get to this number is just a real reduction in the manual staff touches and processing times with automation, being able to do more with the existing team that they have, which is a common ask for many organizations out there, right? So, Tim, do you want to talk about just authorization days out in the metric and how how many of your clients are utilizing that?
Yeah, it's great for a number of reasons. The further out you can get from a date of service to secure that authorization is great from the provider perspective. You're going to have much happier doctors, much happier clinics when you're scheduling something like, say, a critical surgery that needs to happen for a particular patient. It's also going to be a big patient satisfaction, a patient satisfier. In a lot of ways, the patient's not having to wait until, say, the day before the surgery before they figure out if they're going to actually be able to have the surgery or not. So not only tracking this, but setting targets for yourself. And actually, NAHAM, which I think it was mentioned earlier, I'm very close with NAHAM and what they do. They've got a best practice metric around this that I think will be very helpful for a lot of people. So just tracking this and knowing what to do with it and what to kind of set targets for yourself on, again, based on service type and service line is going to be very helpful for the org.
Yeah, I certainly learned about this the hard way as a surgeon, where I had surgery cases canceled either the morning of or the day before, saying, "Hey, look, Dr. Kim, we have not been able to secure an authorization, so we're going to have to cancel and reschedule." And believe me, that is not a position that any of us want to be in, especially patients and families. So certainly an important measure that actually brings together a lot of the things that have to go right. You have to get the approval, you have to get them submitted in time, and get the response in time. So. All right, we'll go to the next
I
slide.
will also say on that, just to kind of, add to that, it's not all payer side with what the off days out is going to be. I mean, especially with like your more advanced procedures or things that you're having to have done.
Mhm.
You have to make sure that you have the appropriate clinical documentation and the appropriate orders and everything in place that you're submitting over to the payer in enough time for them to be able to review and then provide a determination. So if you're having off days out problem, it needs to be kind of a comprehensive review of your process, both from what your interactions are with the payer and then how you're kind of following up with the payer, but also what is your relationship with the provider? Are you getting the appropriate information that you need to be able to do your job as the authorization user?
Yeah, that's a great point. And once again, this is really an overall health check, right? Because you do have to make sure all the different documentation's correctly done, that your team are actually submitting and then also checking, right? We frequently run into examples where there's an approval that has been sitting in the website for more days than probably you'd like. That factor into this that can help factor into the authorization days out. So it's a very nice overall health metric, I think, in terms of some of your practices and processes in place when it comes to authorization. So next slide. Another one, and certainly this is something that another one of our clients, Kern Medical, has also been gracious enough to present at the NAHAM conference recently. There is a specific NAHAM access key that I'll let certainly Tim talk about, but really kind of authorization resolution rates for the number of encounters that should have had an authorization done. How many are you actually successfully completing out and resolving? Prior to working with us, the current team was right around what is considered to be a good benchmark at about 68%, and then being able to really up level that and supercharge that to close to 97%. Another metric there is authorization denial rates as it pertains to authorization related denials in terms of specific denial codes that people are receiving prior to Valer. And this is once again a heavy Medicaid market. 17% denial rate down to 2% as kind of a time and snapshot of having better visibility into the processes. Tim, do you want to talk a little bit about NAHAM here and some of the access keys that are available when it comes to understanding some benchmarking?
Yeah, NAHAM is very near and dear to my heart. I've been involved with this organization for over 10 years at this point, and it's a great organization. They're probably one of the premier organizations in terms of just tracking overall best practice from a national standard perspective. The access keys, which would one of the key you're looking at here, there's about 35 different access keys that you can track best practice metrics against. The auth resolution rate is really looking at, how many authorizations are out there or are pending, and how many of those are resolved prior to or by the date of service. So they have a good, better, best model. Good being 70%, better being 80, and then best, I think in this case, was 90%. And they update these every few years. So as more data comes in, and as trends and processes and organizations kind of change their approach to certain things, they will also update the keys to make sure they stay on top of the best practices. So if you're not affiliated with NAHAM or never heard of NAHAM, it's National Association of Healthcare Access Management. Fantastic organization. They've got a great community. They hold an annual conference. I think this year it's in Phoenix, or in 2025 is in Phoenix. I would very highly recommend just going out there, looking at it, and then, looking at all the information they have available to you.
Yeah, we certainly have gotten to know NAHAM over the past year or two, and a great set of people, and then also resources for patient access professionals. All right, next slide. All right, Bill, I think do you want to kind of take it from here?
Sure. Yeah, so I'll pose these questions maybe to Tim, if you don't mind, Tim. Really the question is, what can we do to measure and meet KPIs, right? So it's one thing to maybe have KPIs in place, but it's another thing to actually meet them or hopefully exceed them. You have any perspective on that?
I do. A lot of what I'll say is going to be somewhat dependent upon the EMR that you use too, and what capability that EMR has, or what particular vendor you may have in place that uses the authorization. But timestamp your data as much as possible. So have an idea, say if you're a Schedule First entity, when was that patient scheduled? When did the auth start? When did you initiate the auth? When did you get the response from the payer back? And start measuring the distance and time between these key timestamps when the auth life cycle essay, just to track and see if there's something that looks a little off or a little out of whack compared to what you expect it to be. Make sure that you have if you're a central organization, or even not in some cases, you have some kind of a work list or work queue that you're able to work from in order to better optimize the way you manage the people, the process, and the technology that you have in place, just because that's going to give you a step-by-step process from a patient perspective on what needs to happen next and why. You can also prioritize that work list to, what's the next date of service? What's the more urgent case? Make sure you have a lot of those things kind of in place and ready to go. That's going to help you monitor your FTE productivity and the authorization productivity in a good way. Have a good relationship with your ordering providers, especially in the cases where you're, like, say you're an imaging center and you have a lot of independent providers that may not work with your health system. Work to create those relationships, either yourself or through your team, or if you have kind of provider relations department with your organization, go out there and build relationships to help them better understand why it's important, not only for you as your entity, but also for the provider, for you to be effective at your job. And I'm more than happy to talk more in more detail about that particular one, because that's something I'm very passionate. I think that needs to be a very clear understanding between both parties, the provider and the actual service. Because that's one of the key components that you're going to have. And then implement prior auth automation where possible. Again, depending on your EHR, in some cases, a lot of that can be, built or baked in the case where it can't. Companies like Valer can do a very good job of doing a lot of that automation for you, but there should be no reason you're touching and having to process a order for or any type of service really for something that doesn't require an authorization. That should be automated. That should be kicked out and ready to go. If you're able to automate any part of the process to go out and look at the payer portal and find when a status has been returned and they are authorized, don't depend on a user to do that when they get around to it. You're going to have sometimes, in some cases, days for you to do anything. Have a bot do that for you. Have some kind of a machine do that for you, and that's going to drastically improve your overall productivity. And it's probably one of the key factors in creating an ROI for implementing those types of processes long term.
Thanks, Tim.
Absolutely. I'm sorry, I can kind of ramble when it comes to those types of KPIs.
No, it's all great perspective. I'm sure it's helpful for our audience. So we're really sort of coming to the end of the presentation portion. We thought we'd leave you with just a couple of really basic next steps. I think when Steve and I, and probably Tim too, speak to folks each day. We'll ask about what KPIs they have in place for their prior authorization management, what sort of solution they have in place to measure those KPIs. And usually you see a sort of a shrug, it's sort of a big black box for most healthcare organizations. So if you fall into that camp, just know that you're not alone. There are some organizations we speak to that do have some sort of solution in place. And so I think if you have some sort of prior authorization management solution, automation solution in place, be sure to ask your vendor, what reporting they do have available for their submission and verification process. It's really important. That's a lot of what we have covered today and is arguably the most ambiguous part of prior authorization management. And then whether you do or don't have a means of measuring your key performance indicators, we would certainly be happy to help you in any way we can. Answer questions, provide some perspective, problem solve for you. When I say we, I'm talking about a combination of Valer. Again, we're an automation technology provider. And then also Tim and his team at the Wilshire Group are a wealth of knowledge for those of you using a variety of EHRs, in particular those in hospital and health system settings. You can see the URL that the website address is there. I'm also going to bring up some specific contact information for both Steve and Tim here in a moment. But just know that you can come to either of our websites, fill out a form. We'd love to hear from you. And again, I'm going to share some additional contact information here next. I'll pull up that screen as we answer a few questions. We've had several questions come in, which we'll begin to address now. We're right on time. So with that, let me start from the top. First question comes from Candace, and she asks, for productivity, curious to know how you're measuring true completed authorizations versus those that have been submitted and pending insurance. We want to give credit appropriately to the team and also give the organization the amount of work that has been done. So this really sort of gets back to capacity planning and staff performance.
Well, I'll take that one because this is something comes up all the time in the
Yeah.
clients and partners that we work with. We absolutely do have the capability, Candace, to create credit reports for interval statuses like pending insurance or payer review, and to then go ahead and check back in to verify the status. And so those are things that we do have the ability to customize in terms of reporting to actually, in fact, give the team members the credit that they deserve, right? If they are doing work to go ahead and check in payer websites, organizations have a difficult time providing that credit. We can do that. Having said that, we also automate the process of status verification, so that kind of goes away a little bit. But there are definitely ways that we want to make sure that your team is getting the appropriate credit that is due when it comes to looking at productive capacity.
Yeah,
hopefully
just kind of behind the scenes of what Valer can do from a data tracking perspective. I think you guys do a very good job of tracking the user that will do the submission and how long it takes, and how many they're able to do on a daily basis. You shared some of that earlier, but it's the wealth of data and wealth of knowledge there.
Steve, maybe I'll pose this next question to you as a physician. The question again from Candace is, what strategies have you found successful in improving the information that is coming from the clinicians with the order, which is really the beginning part of that prior auth process?
Absolutely, as a physician myself, right? So one of the things that we've actually that I found useful in terms of getting providers to pay attention to some of the clinical documentation pieces that need is really having that denied or more clinical information reporting available to put in front of physicians. Certainly, we're, as physicians and providers, always frustrated when our patients do not get the approval. And the ability to have that tracking for what are the reasons why this was delayed, whether it was more information was required or the appropriate clinical documentation was not in place. I certainly utilize that to help kind of provide that feedback to individual providers to say, hey, look, we need some help with clinical documentation. to make sure that this is a smoother process on behalf and the benefit of your patients. And so actually one of the reports that we have created for a client is all the denials for specific providers by their request by specific payer website or portal and plan and down to the CPT code level. We can provide that granular information. I will tell you, it may not work for all your providers. Some of us are a little more stubborn than others, but you can make the argument saying, hey, look, we're trying everything we can. We do need additional information from you on a pretty regular recurring basis if you'd like to get this patient the service that they need. And so that has been a useful strategy to help work together, as Tim referenced, and having that relationship with providers, because they're going to have to do the clinical documentation to help justify the medical necessity for service.
Mm-hmm. Yeah, to add to that, I think being more political and more, you attract more flies with honey than you would with other things is going to be very helpful there as a first attempt. Working with your organization's provider relations team is also very helpful. That's their job, is to go out there and make sure, specifically with independents, that you're getting your point across, that this is not only a benefit for you as your organization, but this is a benefit to them as the provider, but also a benefit to the patient that they're attempting to care for, and their inability or lack of documentation when they're submitting the authorization is going to hinder that. If that doesn't work, if you just got a very non-compliant, you could unfortunately just say that we're not going to be able to schedule this patient until we get X from you as the clinic, and put the onus back onto the provider to get a lot of that taken care of before you can do anything. That's typically something I would view as a last resort, but it is something that I've had to do in my operational days from time to time, just to say, I need to have this done. I'm sorry that it's come to this, but I need to have this done.
Yeah, it just reminds me, we've actually had a client where we produced a status which is pending final note or signature from a physician, so that we could actually timestamp that. So when the complaint is, well, how come this authorization hasn't been done or my patient hasn't been scheduled, we could actually, there was one client that was measuring by provider how long it was taking for them to finish and sign off on their clinical notes for submission. So just some different strategies to utilize. Certainly, we have the ability to provide certain elements of data to kind of put in front of providers to see if that will help the conversation piece, if you will. But as Tim says, honey always works a little bit better if that's possible. But just being a provider myself, sometimes it's not always going to get you the results that you need to work on behalf of the patient. So.
I'll ask this next question, maybe with Steve to start. What specific IT companies do you know that can help with prior authorizations? We sort of teed that one up, Steve, but I can also add to that a little bit as well.
Yeah, there's certainly a lot of IT companies out there that do support prior authorizations. Obviously, that's kind of where one of the focuses that we have in Valer. In terms of prior authorizations, there's a lot of different components to that process, and where we kind of sit is really around the submission and the verification, the manual aspects of it. Obviously, many of the other large RCM vendors, the Experian, the Waystars, et cetera, do have, there are quite a few IT vendors out there that do have services related to prior authorizations. We certainly have seen other vendors who are in the space of trying to do the is auth required or not in terms of the payer rules. So, so there are quite a few out there. I think there's a question in the chain about Epic and payer platform. Certainly, there's aspects to Epic that where they also have some functionality and capability around prior authorization. So there are a number. It's really of looking at kind of where are your pain points and challenges, and kind of where the help is needed, and to take that into consideration when you're looking and talking to different vendors in the technology space.
Great. Now, I'll also add too, Steve, if you go to Valer's website at valer.health, we've got a list of terrific partners that we work with. I know the question is specifically about IT, but those include services. Obviously, the Wilshire Group is a key partner of ours. Tim and his whole team have done a great job. But we have a host of other partners, again, on our website that you can reference if you're interested in which partners could combine with maybe implementing Valer or potentially other IT solutions. One other question that we get quite often, Steve, I'll ask you to tackle this one, is how many payers is Valer connected with, and how long would it take to implement a new payer?
Yeah, it's a great question. Obviously, our fundamental approach from the get-go in my own practice was covering all the payers that my team needed to deal with. And so what that has translated in is we look at the different payer websites that many of the health plans and payers are utilizing. We have over 75 of many of the major national payer websites that you may all be familiar with, as well as some of the major insurance payer portals out there, as well as your local and regional portals. And so part of how we work and how we work differently is our process is to build automations for your specific set of insurance payer websites that you have to go through, not just the major ones that are well known and out there, to really provide that comprehensive approach. Typically, for most of the payer websites, it's a 1 to 2 week build process that we kind of go through during the broader build process for an organization, for a specific team, and to incorporate that in. When it comes to fax forms, I know many of us don't want to believe that fax forms are still alive and well in healthcare, but we have well over 1,000 unique payer fax forms for all sorts of different services, and we continue to get them every day. And the turnaround of getting those brand new fax forms in is generally under 48 hours, sometimes even the same day. So one of our approaches is fundamentally not to restrict the workflow automation that your team needs. And so we have the ability and capability to build out all the different portal automations and fax form automations that a particular client may run into.
And Steve, maybe we'll make this the last question again to you. Is the question from Kay is does Valer have any Oracle Cerner clients?
We do. We have Oracle Cerner clients, obviously, on a couple of different configurations. So yes, we do have some Cerner clients. One of the case studies was from a Cerner client. I apologize. There's some noise in the background if you hear that. But we also have Epic clients. We have Athena clients, Veradigm clients. So we're very adept at working with a lot. And Oracle Cerner is certainly one of where we're doing a lot of work in. So.
Great. Well, with that, we are coming up a few minutes to the top of the hour. So I want to again remind you that you'll receive a survey when you close out the webinar today. We would really encourage you to take that survey. It'll just take literally 1 minute or less. 5 questions. Please let Steve, Tim, and me know how we did today, where we might improve. And importantly, if you'd like follow-up from either Valer or the Wilshire Group, please let us know in the survey, or you can contact us again at the email addresses on your screen. As a reminder, you'll receive both the slides and a recording of today's webinar by next week. If we don't hear from you and speak to you, I want to wish everyone on behalf of all of us a happy Thanksgiving next week. Enjoy your weekend, and thanks again for attending today's webinar. We'll look forward to hearing from you. Take care.
Thank you, everybody. Really appreciate it.